This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal Child's Nervous System, published in early 2026. The paper is titled Management and Outcomes of Craniectomy and Cranioplasty and Pediatric Intracranial Infections, a multicenter cohort study.
This is a particularly relevant topic for those of us in the trenches. Lately, it feels like we've seen a noticeable increase in severe intracranial infections, things like subdural empyemas, brain abscesses, and ventriculitis in our pediatric patients. These are life-threatening conditions that demand urgent intervention.
Absolutely. The authors point out that while our management strategies vary from simple craniotomy with debridement to full decompressive craniectomy, the real black box is what happens after the acute phase. Once you've performed a craniectomy to manage pressure or infection, when do you put the bone back? What material do you use? It's a major point of debate because in the pediatric population, complication rates for cranioplasty have historically been reported as high as 42%.
That's a staggering number. So let's dive into how this study was structured. They looked at a multicenter cohort, correct?
Yes, it was a multicenter retrospective cohort study covering a decade of data from 2013 to 2024. They identified 76 children with intracranial infections. To give you an idea of the severity, 37% of these children required a decompressive craniectomy. Out of that group, 21% eventually underwent a cranioplasty using various graft materials.
Let's talk about that initial stage. For the residents listening, what were the clinical or radiological markers that pushed these surgeons toward a craniectomy rather than just a standard craniotomy?
The study found a few significant associations. Craniectomy was significantly linked to the presence of sinusitis, with a p-value of 0.025. This makes sense clinically, as we often see these infections spread from the frontal or ethmoid sinuses. But what was perhaps more striking was the clinical presentation. The presence of paresis was strongly associated with the need for craniectomy, with a p-value of 0.006.
That's a critical point for our residents in the ER. If a child presents with an intracranial infection and focal neurological deficits like paresis, you need to be prepared for a more aggressive surgical route. Now, what about the microbiology? Did they find a specific bad actor in these cases?
They did. Streptococcus intermedius was the predominant pathogen identified specifically in the craniectomy group. The association was highly significant, with a p-value of less than 0.001.
Streptococcus intermedius, part of the ganglionosis group. It's notorious for being aggressive and causing rapid abscess formation. It's interesting to see it so clearly linked to the need for bone removal in this cohort. So the patient survives the initial infection, the brain settles, and now we're left with a skull defect. Tell us about the reconstruction phase.
This is where the study gets very encouraging. They analyzed 16 patients who went on to receive cranioplasty. The median timing for the reconstruction was 6.9 months post-craniectomy.
Nearly 7 months. That feels quite conservative, but in the context of a primary infection, it seems they were prioritizing safety to ensure the field was completely sterile.
Exactly. And that patient seems to have paid off. While adult neurosurgery often see cranioplasty complication rates between 15 and 41%, this pediatric cohort had a complication rate of only 6.25%. That represents just one instance of wound impairment in the group.
Only 6.25%? That's remarkably low for a post-infectious reconstruction. Usually, we worry about the dormant bacteria or the poor scalp quality after multiple surgeries.
It really highlights that with careful timing and individualized material selection, which they noted were essential, you can achieve safe outcomes. They used various graft materials, tailoring the choice to the specific needs of the child.
And what about the long-term functional status? Did the cranioplasty actually help these kids recover, or was it just for aesthetics and protection?
The data suggests a real functional benefit. The study found that functional outcomes improved significantly in patients with hemicraniectomy after their cranioplasty. Specifically, they saw favorable modified Rankin scale, MRS, scores at the 3-month follow-up, with a p-value of 0.037.
That's a vital takeaway. Cranioplasty in these kids isn't just about closing the hole. It's a restorative procedure that correlates with clinical improvement.
It's also worth noting the author's conclusion that despite the rising incidence of these purulent complications like subdural and epidural empyemas, the management path they've outlined involving delayed cranioplasty is highly successful in this vulnerable population.
To summarize for our listeners, in pediatric intracranial infections, watch out for sinusitis and paresis as red flags for needing a craniectomy. If you see Streptococcus intermedius, be ready for a potentially more aggressive course. And when it comes to the cranioplasty, waiting about 6 to 7 months appears to yield very low complication rates and significant functional improvement.
Very well said. It's about balancing the urgency of the infection with the precision of the reconstruction.
Thank you, Dr. Ilara. And thank you all for tuning in to the Neurosurgery Hub podcast. Stay sharp and keep learning.
We'll see you next time.